Welcome and thank you for joining us on today's AI Explained. I'm Krishna Gade, the founder and CEO of Fiddler AI. I'll be your host today. You can put your questions in the Q&A box anytime in the fireside chat. Today's session will also be recorded and sent to all the attendees after the session. We have a very special guest today on AI Explain, and that is Dr. Stacey Johnston, CIO and Digital Execution Officer at Beacon Health System. And today we are exploring with her on AI in healthcare and ROI, governance, controls, observability, all of those fun things. Welcome, Dr. Johnston.
All right. Thank you so much.
Dr. Johnston joined Beacon in October 2024. She most recently served as the Vice President Chief Applications Officer for Baptist Health in Jacksonville, Florida. Prior to that, she was the Chief Medical Information Officer at Beaufort Memorial Hospital in South Carolina. During her time in these roles, she always maintained an active medical staff privileges, worked as a hospitalist, and she plans to continue this as she feels it gives her a unique insight into how technology and care intersect. And prior to this, she received her bachelor degree from Washington College and Doctor of Medicine degree in Emory. So great to great background, and it's great to see technologists coming from different backgrounds, and very excited to host you here, Dr. Johnston.
Well,
So
again, thanks for having me. And now my camera's working, so we're good now.
awesome. So I guess let's start with that, right? Like you started as a clinician. What moment made you realize that healthcare needed systems level change and not just bedside care?
Yeah. So honestly, a lot of this actually started straight out of residency. Back in the day, we were still on paper records, and then we were switching over to electronic health records in residency. And of course, at that time, many attendings were not super excited about it. So of course, they gave it to the residents to try to figure it out. And even the residents were raising concerns and saying, one thing I've heard a lot over my tenure in this role is, we are the highest paid secretaries out there. And so this idea of putting in our orders, typing them in, which just went against everything a lot of people were trained, to do at that time. And so what I realized was either I could buck the system. I mean, this was coming whether we wanted it to or not at this point in time as a regulatory requirement. And so, I could either buck it or embrace it. And so
Mhm.
what I realized was if I embraced it, it made my life easier. The more I embraced it, the more time I spent in developing my documentation templates or my order sets, just kind of made my workflow easier and therefore made my colleagues' workflow easier. So at that time, I was in family medicine and then became an attending as hospitalist. And interestingly enough, I went back to paper.
Mhm.
And so then led a second round of implementation of paper to an electronic health record. By that time, I was the only person in that health system at Beaufort that had been on any sort of CPOE. So next thing I know, I became the chief medical information officer. And that was that mindset of, okay, if we spend time in the beginning really evaluating our workflows, trying to make them better, by using the systems, how can it save us time in the long run? And so versus if we don't put what it called care and feeding into the EHR, then it's just gonna, all that pajama time, all of that, that was happening in real life. And so I really spent a lot of time on the hospitalist workflows and on their order sets and,
Mhm.
automation and using Dragon Medical One and the templates. And so really building up our templates, really building up auto text. And so the more we could, and that was the version of automating back then,
Mhm.
was templates and even the Dragon Medical One. And then we went to the DMO mobile app. I mean, we're like, oh my gosh, this is amazing. And like AI wasn't even uh and a
Thing that, yeah,
thought. Yeah.
yeah.
I mean, no one even thought that that was even possible. But what I realized was, taking the time to make it better for the physicians ultimately ended up making it better for patients. that decreasing time in the EHR obviously is, that EHR can contribute to burnout, and burnout obviously leads to a lesser quality care. And so we really, initially that triple aim that you might have heard about is, good quality care, reduce cost, and, more about the patient. And then adding in the quadruple aim was really talking about enhancing the caregiver experience. So I really took that to heart and, making the caregiver experience better. And then now they're talking about the quintuple aim, which is equity in care. So, I still think we have a lot of room to go, especially in those last two components, enhancing the caregiver experience and then in the equity of care. But I really think that, now in this AI era, we're just getting the glimpse of it, like just a little taste of it. We're doing a lot, radiology's embracing AI pretty well. Um, there are some cool note summarizer type of things, but we're not full AI in the clinical space yet. And
Mhm.
I think once we get there, of course, through, change management and appropriate data and trusting of the systems. Um, we're still, I think, maybe a year or two out from that. But
Mhm.
once we get there, I think the sky's the limit. And I think the docs are really going to see time spent in the EHR is decreasing. They're going home on time.
Mhm.
They're starting to find joy in medicine, really embracing ambient, but more than just documentation, from the ambient listening, but really doing your full workflow with an ambient solution, I think is ultimately where we need to go.
No, it's great to see technology helping practitioners that way, right? Now it comes to no, so it's an interesting because you had this two kind of split level experience. In some ways they're connected, but what do you see? Like technologists, pure play technologists, fundamentally misunderstanding what clinical.
Yeah, I think ultimately, spearheading technology is it's not a technology issue. It is a workflow issue. It is a
Mhm.
change management issue. It's a training issue. And so if you do not understand and embrace the workflows, if you don't understand the needs for change management, or if you don't really have a good training program around these AI solutions, then you're just going to put them in and they're going to fail, And so there are going to be a lot of times um, where we implement and it's not meeting our needs. And well, why isn't it meeting our needs? Well, chances are we put in something because, maybe the operators thought it would help solve a problem. But ultimately, one of the things as being an informaticist is you learn, to ask the question, what problems are you trying to solve? And maybe the problems of the physicians aren't necessarily aligning with your hospital operators. And so you need to make sure that we're in alignment from a system, what problems we truly are trying to solve. And that, if you can get your service line leaders, your physicians all to be in alignment. And, maybe it is about access for patients. And maybe it's about, physician burnout, but whatever problem you're trying to solve, we need to make sure that you're aligned from a system and you have a singular system approach to that problem before trying to deploy the solutions.
Yeah. Interesting. And now we are in the biggest technology shift now era, right? Everyone is saying that AI will transform healthcare, especially in from your perspective, what's actually working today? Is it still kind of PowerPoint decks, or are there any interesting applications that you've seen work, and giving ROI?
Yeah. So, I think most health systems are advancing themselves in the back end pieces, automatic coding. We are pursuing fully autonomous coding, which I think
Mhm.
would be, a game changer for us. Right now, it's still mostly an augmented coding aspect. We are moving towards fully autonomous verification of benefits, where an agentic AI solution is going to do all of the verification of benefits. We're also looking at agentic call return. And so agents actually participating in, voice call returns and, interacting with the patients. So there are some really cool solutions out there doing that. Other areas where we've actually expanded into agentic use, fully autonomous agentic use is when we converted, we actually just did a 4-hospital acquisition recently, and we put them on our tech stack in 7 months, which was pretty aggressive. But, you only get this system available to backload appointments. We got it about 2 weeks before we went live, and 2 weeks to backload 100,000 appointments is not necessarily enough time. So we had to think differently. We could either hire 40 people to do this, or we could use some agentic AI. And so we were able to basically do all of the ambulatory backload appointments with an agent. It took us about 3 weeks to build the agent, and then 2 weeks from that time that the system became available to backload all of the appointments. So that was game changing, and that was fully autonomous agentic AI, and doing all of our scheduling for our patients. So I think that's pretty cool. We're looking at some digital FTEs and, all these repeatable processes. We have a pretty good, robust robotic process automation program. We have a good intake process and a governance around the RPA. But imagine laying an agentic AI solution on top of your RPA. We're not there yet, but I think that's just, that's right around the corner as well too. So those are kind of all of your back end processes. And then when you
Oh, that's
think about
awesome.
yeah, when you think about the clinical aspects, we actually have a white paper that has been written about agentic AI and colon cancer screening. So really embracing the use of Cologuard and as an initial screening instead of automatically going to a colonoscopy. And a lot of this has to do with access to colonoscopies, and Cologuard is now being
Mm.
viewed as, a good first solution. And so we built an agent that automatically ordered Cologuard for this group of patients that qualified. So we ordered 7,000 Cologuard screenings, and ended up getting back. I think it was about 40% returned, and ended up doing 250 colon cancer screenings. Additional with a colonoscopy, and we did actually have one positive colon cancer return that was caught early, so had a resection and full survival. So I mean, that is game changing, clinical care where an agentic AI solution can actually help prevent, further mortality. So I think that's pretty cool stuff.
Wow, that's awesome. So automating appointments to clinical diagnosis. So what is like maybe like maybe you can give us like our audience also like what's one use case that's often overhyped and also what's like you think that is underappreciated, both like in your experience that you've seen with AI.
Yes. So one use case, so obviously radiology, a lot of the radiology
Mhm.
use cases are fully embraced. Um, I don't know that I don't know of any organizations that are fully autonomous with radiology yet. We are using it as an augmentation to the workflow. So I think that's one that isn't overhyped, but is definitely used,
Mhm.
throughout multiple health systems.
Mhm.
And one that I think is underappreciated is the augmented responses to the in-basket messaging. And I think part of it is just understanding, the large language model
Mhm.
and, having to say, well, I have to modify the message anyway. But yeah, modifying a message that's already written up is very different than typing a brand new message. So I think that's one that we should continue to explore and push ourselves on. There are studies out there that show that our, especially our primary care docs, are getting 85% more in-basket messages from the portal. These portal messages are since COVID. And so, that's additional burden. Again,
Mhm.
the cognitive burden for our physicians, but yet also it's not being reimbursed. It's not, it's just additional time for our providers. The other thing is we need to look at the pools for these messages. Does this particular message really need to go to that provider, or can it go to an MA? Can it go to the front office staff? So I think routing the messages better. And then when it truly is a provider message, having the AI help queue it up. I think also some referral management is not as well utilized with AI. we're diving into that. Refill management, so refill medications, I really feel like as an opportunity with AI. Again, cognitive burden. What is a repetitive task? And so can the AI queue up the refills that are ready so the docs aren't having to click on those boxes all the time? So there are some solutions out there that are doing some pretty cool stuff with refill meds.
Awesome. So we touched upon a few things, right? You leveraging large language models to respond on behalf of doctors or even augment, their answers. Now, one of the problems with LLMs is that there are a bunch of risks. They can hallucinate at times. They could, leak PII information and all of that, or PHI in the case of healthcare. Um, how do you, when you joined, Beacon, how did you approach this problem of AI governance, and where did you begin?
Yeah, so great question. So we at Beacon, upon my arrival, didn't really have a good, strong IS governance process. So it was IS was either the approvers or non-approvers, and it was kind of just tickets were submitted and people didn't hear back, and it was just not a great process. So that's actually the very first thing that I did when I came here was stand up an IS governance process. So we have an executive steering committee. We have 8 different advisory levels, and then we have multiple work groups that report up to the advisory councils. One of the advisory councils that we did stand up is an AI council. And in that AI council, we developed 2 AI policies. One's basically an AI policy, meaning that, you don't go out and just sign up for AI. It has to come through the advisory council for approval. And that, if you use AI, it has to be like a system approved AI. So kind of more about like how to use AI. And
Yeah.
then we have a permitted and prohibited use policy, meaning I can't put PHI into ChatGPT or into open evidence, something along those lines, but that we do have permitted clinical uses, which is more like augmenting the workflow. So this ambient listening, the Oracle's clinical AI agent, but you might use a bridge or, DAX Copilot. So, some of those solutions that, are augmenting your workflows. So you're still reviewing and you're signing off on that documentation. So in the radiology space, it's an augmentation to the workflow because it queues up the severity. So, if they get hundreds of CTs a day, it will do the read first, and then it will queue up to the radiologist. These are ones with results that we think you need to review first. And so it actually helps them become more efficient because
Mm.
they can then, read the most urgent reads first and then go to the, more of the maintenance reads. So there's just a lot of cool things that we can be doing, but we need to make sure that we are governing it. So it comes through the AI Council for approval. There is a form that we created that the actual companies submit and fill out themselves. So it's about, what does your data modeling look like? What are you using a LLM? Which model are you using? What are you monitoring for drift and bias? Where are you storing the data? So basically some vendor, it's like a vendor risk assessment, but from an
Mm.
AI risk. And then we are also we've done double down on our AI literacy program. So
Mm.
now we built out an AI literacy program, and it's required training for our managers on up, which is essentially to help us look for drift or bias or anything that is starting to help us like manage these AI agents. As you might manage an associate, you need to start managing these agents themselves too. Um, and then it also helps us understand like what's a permitted use, what's not permitted, so that we don't have our individual team members doing something with AI that they shouldn't be doing. And then one last component of governance is there are a few solutions out there that are doing AI monitoring. So overlaying another solution on top that is monitoring the AI for drift, for bias, and then they would escalate their concerns to the leadership if something seems amiss. So it's kind of like you have these security for monitoring for network, and it's basically another security metric, but it's monitoring for AI use.
Yeah, makes a lot of sense and very relevant to today. So I guess, fundamentally, right, like it all comes down to trust and safety and governance. What does trust in AI look from a hospital board's perspective? Like, because as you think about, like potentially AI recommendations conflicting with clinician judgment, or, AI maybe standardizing too much across and losing precision intuition, things like that. So, how do you view of this the world of like trust in AI from hospital perspective?
Yeah, so I think the administrators and operators are the leadership is most likely to embrace AI and trust it at this time because they've seen it successful in the back end processes. So for instance, our revenue cycle team, they're on full on AI. They're like, the more AI can layer on, bring it
Mm,
on. And
mm,
so they've actually been great to work with. They are actually kind of leading our organization with the amount of AI they've embraced, which then made it easier to tell our referral team, hey, we're going to embrace AI for your referral management. And okay, now we've gotten that. So now let's dive more into the clinical space. The AI that's more of an augmentation to a workflow. So as I mentioned, in basket messaging, the clinical AI agent, we've really adopted the clinical AI agent, which is our ambient listening solution to queue up the documentation. So about 70 to 80% of our providers and the ambulatory clinics are using the ambient listening solution for their documentation. And about 70 to 80% of their notes are generated with the ambient solution. So it's being very widely used. Part of that was we trained them. We spent a lot of time training them on how to use it to help them become more efficient. And they saw their documentation time go from 7.5 minutes per note to 2.5 minutes per note. And
mm,
so the fact that they saw the value in it and that they were starting to see that the note was actually producing a good quality note. So they trust that. Now,
mm,
if I were to say, I'm going to totally turn it on to be fully autonomous and you don't even get to read the note, I don't think we're there yet. They're not
mm.
trusting it enough. And so so you've got to move the needle a little bit, have them trust that one component, and then move the needle again, have them trust that component. And so it's just a natural trust that builds on top of each other as you start to expand more.
Very interesting. And like I think this is a great ROI thing that sort of mentioned, right? Healthcare industry runs on thin margins. You probably have to justify your AI investments. Where have you seen like the fastest payback? Like cost reduction, clinician productivity, or new revenue?
Um, yeah, so I think that's still kind of for us on the back end pieces. Although I do have to say the clinical AI agent, I remember when we first deployed it at another organization, it was, gosh, I don't know if we can afford to deploy it. Do doctors pay for it? Does the hospital pay for it? And there's no ROI. Maybe they might see one more patient per day. Maybe they won't, and so but what we have actually found is we've been live for about a year and a half. And in, over a 12-month period of time, we had an extra $10,000 per doc revenue and just better capturing of the documentation of the visit. And so there was a definitive ROI by going live with the clinical AI agent. So then we're like, that's a no-brainer. Let's just keep rolling that one out. Um, so and the other
And
one,
what does this clinical AI agent do actually? Can you double click
it's
on
like
that?
the Abridge. It's within
Okay.
Oracle built it, but it's like the DAX 360, the Copilot, the
Right.
Abridge, that ambient, it's conversational
Yeah.
AI that you have with your patient, the provider and the patient that then queues up your documentation template
Mm-hmm.
to review.
Mm-hmm.
But that one's built within Oracle by Oracle.
Mm-hmm.
Um, and um, the other one that, again, received great ROI was the colonoscopy. So
Mm-hmm.
why not fully, the Cologuard, why not fully automate that? Like,
Mm-hmm.
why can't that be a fully autonomous decision? That if we have based off of your inclusion criteria and we know your exclusion criteria, why isn't isn't an agent just automatically ordering the Cologuard screening?
Mm.
I think that's a great use case. And then, for all of the decreased colonoscopies, unnecessary colonoscopies, and increased in appropriate colon cancer screening, then, which is tied to a lot of the, 4 and 5-star metrics from your Medicare Advantage plans. So, why not do something like that?
Mhm. Yeah, it makes sense. And as you bring these multiple tools, right, like you mentioned, clinical agents developed by Oracle or Abridge or other systems, are you seeing like the need for a centralized control plane emerge where you are able to track all of these agents in one place and how know how they're performing?
Yeah, AI reports to me. I've formed a department of AI and transformational technologies, and we are a centralized process at this point in time. However, um, the recommendation and the studies are showing that you're more likely to embrace AI if it's more of a federated model, more of a decentralized model. However, I still think the monitoring should be centralized.
Right.
And so what does that, federated decentralized model really look like? Well, that means that, you've got your departments owning, just kind of day-to-day monitoring of the AI. Does this still make sense? What is my adoption rate? Are these metrics meeting, my needs? Is this AI no longer needed? Do we turn it off? I mean, that's something we never ask ourselves in
Mhm.
technology is, do we turn off these systems? Um, and so I think the monitoring still should be a centralized process, but how well you adopt and deploy the AI's agents or, any RPA or anything like that, I think we can start to move towards more of this federated model. One of the things we're talking about developing, and there are some organizations that are doing this really well, which is this AI citizen program, which is you can start building out like low code, no code yourself. And so we have Microsoft Copilot, and if with the higher level license, you can actually start building out some of your agents. And or do we use that? Do we use UiPath, where you can maybe build out your own bots? And so how can we actually, through an approval process that may be more centralized, then give people the tools to actually build their own bots? I think that's where we want to go, but we're not quite there yet.
Yeah, makes sense. Makes sense. And then, like, as part of this control plane of centralized observability, is there a need for a runtime AI governance, like almost like that Redux PII before I think this is an audience question I'm reading out, that Redux the PHI before any information enters the LLM. Uh,
Yeah, I mean, obviously, I think you have to be real time because without that, we won't be responsive. So, it is, it's critical for you. You need to have kind of your standard processes, but there are going to be times and needs where you need to be a little bit more agile. So how can you have a governance that has a standard process, but yet is agile? I think that's the sweet spot. And I don't know that a lot of organizations are doing that really well. We're not quite in a fully agile yet. But I think having a dedicated AI team has actually made us much quicker.
yeah, interesting, interesting. And then another related question, I'm just taking a couple of audience questions here. Of there are so many there. Please keep coming them in. And so there's one more question from John Sacris on, hi Dr. Johnston, how does Beacon ensure that it is robust in their tool evaluation while not acting as a bottleneck for innovation? I think this is kind of that trade-off between innovation and governance.
Yeah, no, that's always hard. I think that organization is definitely clamoring for more AI, but I brought up in our large system meeting this morning that, hey, we can go as fast as you want. I just need more people to do the work. Are these tools worth their investment? I think so. But if we work on these AI solutions, what are we not working on? So I think that's kind of that, so we need to understand the system priorities, but also as we move into this more federated model, where if it's kind of this low code, no code, or, a simple bot build program, then that I think helps us become more innovative, and that people could actually be building some of their own agents or building their own bots. Um, that's, I think, where most organizations are ultimately going to have to go. And the other thing is that, do you buy or do you build? And we're doing a hybrid of both. So if it's a really complex workflow, or if we need it turned around really quickly, we're going to buy. We're going to partner with someone, and we're going to say, hey, we need this agent built in 2 weeks. Can you, we have it mapped out. Can you build that for us? Versus if you, and if it's a simple workflow, why don't we build that ourselves within our team? I think you're gonna almost have to do all. You're gonna have to be innovative and have a process. You're gonna need to be agile and also look at cost reduction. I mean, you have to kind of do all. And so, what I brought up this morning was, I think, yes, we might be spending more now, but in the long run, it's going to save us more money by reducing FTEs. Or honestly, where we are is we can't even fill those FTEs, so we're paying contractors.
Mm.
And so rather, instead of filling it with contractors, can we fill that with an AI agent that can actually help reduce the workload, so you don't need as many FTEs? So for us, it's not about reducing our FTEs. It's just about, filling the positions we have open or reducing our contractor spend.
No, that's very, very interesting. And so, I guess like for other, AI leaders like you working in healthcare, what's your advice? Like, how do they think about, bringing new AI tools to deployment? What is the one thing to put in place, before they deploy anything in terms of AI, in their
Yeah.
environments?
I do think having an AI governance council and advisory council makes sense. And so we have physicians sitting on it, vice presidents, hospital presidents. We have ethics, we have compliance, we have risk, we have security, IS leaders. So, it's kind of the gamut of, what's going to have, HR. So, we have the gamut of who needs AI and who should be responsible for AI. And that just helps to ensure that we have some responsibility for our solutions. But it, also helps us understand our training needs, our change management needs. So I think that's the first thing. And then you need to understand, the other thing we did very early on was, at a minimum, understand what your permitted and prohibited uses are. Are you going to be, what is your risk for fully autonomous in the clinical space? Are you there yet? Are you not? You need to decide as an organization. And then I would, so those are the first two things I think you need to do first before you really fully expand. And then I would 100% what I did of standing up a department that this is all I did. Because if you add AI on top of your team that's already busy with code upgrades, maintaining your systems, the break fix, the request from, I need to change this order set, this documentation template, we have now joint commissions coming. So if your team that's doing that day-to-day maintenance and, of your systems, and then they're also responsible for going out there and being a partner for implementing AI, I think it's going to be very hard to move the needle. So I think having a team that they don't need to worry about the mundane. Their job is just to go and meet with the business partners, they're going to conferences, they are, meeting with other organizations. They are out there just scanning the environment and finding out what's new. They're meeting with venture capitalists. We're meeting with, we're partners with Notre Dame. So we meet with Notre Dame frequently. What are they working on? What are they seeing? We are setting up some internships with Notre Dame so they can actually do some development in our environment too. So before you get there, though, it's kind of that, crawl, walk, run philosophy. So you've got to crawl first. So choose a couple of good select use cases that you are fairly confident in before you start to, walk and run. The other thing that we do, I forgot to mention with the AI policy, is we only approve at the advisory council if it has a defined ROI. If there is no ROI, then you need to ask yourself, why are we doing it? But if it's soft ROI and it's really going to give back, back to the clinical experience, then it goes to the steering committee, meaning that, do the executives, so the C-suite, do we buy in that we want to give this to the clinical end users, even though we may not get any ROI from it? And so we haven't actually had anything that we've approved without a defined ROI. So right now, you know, finances are tight for all of us. So you all should be looking for ROI first with your AI before really going to the non-ROI initiatives.
Yeah, makes sense. So you got to measure your ROI continuously and evaluate how these things are working. I guess that's important. Uh,
Yeah.
so here is winning the confidence of clinical staff, right? When it comes to introduction of new tools, especially AI, right? What has been your journey uh, in terms of doing that at Beacon? How are you successful or any lessons learned?
And I'm sorry, it broke up for just a second. Could you ask the question
Yeah, so
again?
the question was basically, how are you, one of the problems in healthcare is like, how do you win the confidence of AI clinical staff who might be skeptical about AI and the tools and
Yeah.
what has been your experience doing that at Beacon? Yeah.
Yeah. So I think having key physician partners, understanding their use cases. So I actually spoke at a physician meeting last night, kind of talked about the future of healthcare and the future of healthcare technology. Obviously, AI was probably a number one thing we talked about. And people were, some were reticent, but some were like, hey, I have really great ideas. I'm like, submit them to me. If it's a low hanging fruit, we could put that in, from the time of request to an agent being built is, probably about, 4 to 8 weeks, depending on the complexity. Right. And so why not? If there's going to be ROI there, I don't see why we couldn't do that. If it's obviously more complicated workflow or requires integration into our EHR, that's going to be a longer, ask. Um, but you need to deliver on your promises, and then they need to see the value of what what we've turned on. So, one of the things I always say is don't implement AI for AI's sake. To say you're implementing AI, but it's going to be meaningless to the docs, or make sure you know where that data is pulling from. So again, if you have, different data set definitions and you're pulling from the wrong data set, it's the data, the docs aren't going to trust the data and therefore they're not going to use the systems. And it needs to be easy to use, just naturally intuitive. It needs to be part of their workflow. Asking them to go out of their EHR to use another system, that's going to also not help your case. And so it needs to be seamless, integrating into your system as much as possible. And it just needs to provide some value to them. Either, um, they can see more patients or they go home earlier, they less cognitive burden, one less click, throughout a day adds up, a significant time savings. So, you're going to gain the trust by doing solutions that are easy to use for them.
Awesome. Yeah. And I think once you are able to trust your AI, then you can start thinking about customer facing AI as well, right? That's actually an interesting, question from an audience. How are how are you tracking the concerns? How are you sort of overcoming the concerns about AI agents directly working with patient and sort of and potential patient reactions, dealing with AI agents, what has been, I don't know if you're there
Yeah.
yet or like, how are you thinking about it?
We're looking at it. I mean, we are investigating the AI agents making phone calls. And so, studies have shown that empathy from an AI agent call is actually higher than, a person calling. And so that's probably where we're going to start with our AI true interaction with the patient. Um, Now, there's other things that AI could be doing and that I'd like to pursue, which is really AI detecting kind of emotional or mental crises, when they're calling to make an appointment. There's AI solutions out there that can detect, suicidal risks. So is that something that you want to look at as well too? But I think AI agents calling patients is pretty cutting edge.
Mm.
The other thing that, AI can be doing. There's a lot of solutions out there that for in your inpatient stays, AI and falls. A lot of people are doing AI with fall predictive modeling with camera use. But what about if you could take that and then that if the patient is about to stand up, the agent itself calls into the room and says, "Hey, please sit back down." Or do you need me to call your nurse for you? So having that agent interact with the patient actually in the clinical setting in the care room, that's out there. I mean, we haven't done that yet, but that's definitely on our roadmap.
Very interesting. Very interesting. I guess, coming back to sort of, co-pilots and autopilots in medicine, apart from like administrative assistance and clinical diagnosis, where do you see the world going? For example, if you have to rebuild, the entire healthcare system from scratch today, with AI, what would you do differently?
Yeah, so it's interesting. So Oracle is rebuilding their or total EHR with this new AI semantic layer. And we're going live with it in our ambulatory clinics this summer. So at least in a pilot, a few clinics. So it'll be interesting to see if that
Mm.
significantly changes. But some of the AI things that we need to embrace within the EHR, again, the augmented responses to the patient messages, number one. Number two, summarizer. So kind of what happened from the time I saw you, 6 months ago to now, was there admission? What images were done? Did they follow up on any of their care gaps? What care gaps still need to be done? So basically kind of what happened to now and how can I help keep you healthy? Like layering the EHR on top of large language model to be able to queue that up combined with the ambient solutioning. So then you can review the note summarizer and say, okay, I see that you visited that AD for chest pain. Did you follow up with a cardiologist? No, I didn't. Well, let me place this referral for you now. Let's get you referred. Do you have a particular cardiologist you want? Let's go ahead and order an echo and, follow up with me in a month. That conversation should be actually placing the orders as you're speaking instead of you then getting the document. Right now, it's just queuing it up in the document. You read the document, you submit it, still saves you time. But wouldn't it be great if then it also actually placed those orders or at a minimum queued them up into your in basket so that you just had to sign off on them instead of actually having to manually type in the orders? And because it was using large language model, it could review to make sure you had the right CPT code and the right diagnosis code. And, and it also has access to your referral management system. So it knows which doctor to send it to and the right address. And then the patient gets a text, 30 minutes later and say, "Hey, we got your referral processed. Please, we'll text you again when we have an appointment made for you." So, or text in here, use your texting solution to choose which time you want. So that's where we need to go. We're not there yet, but I definitely think there are some organizations that are doing bits and pieces. Like we're doing the texting and the online scheduling, but we are not fully the note summarizer. We won't go live with till the summer.
Interesting. Interesting. And there was also a question on wearables from the audience, from Melike Gunnar, Dr. Johnston. How are you envisioning utilizing lifestyle wearable data from patients in their care? Wearable devices like smartwatches, rings, wristbands continuously collect data, and
Yeah.
uh, and then how can these data sets be utilized by leveraging AI tools to enhance patient care?
I mean, great question. So, I mean, that's where I think the sky's the limit. So, we've got all of this IoT world, so we have all of this patient data. So whether it's a continuous glucose monitor, blood pressure cuff, we've got, these telemetry devices, your smartwatch, so all of this wearable data, right? And so coming in, and so it can come into the EHR and ingest it pretty easily. That's not the hard part. What the hard part is from where I started at the very beginning is the workflow around that. So if you have someone whose blood pressure is reading at 200, what are you going to do? Like, who's monitoring that alert? And does that alert come to the primary care doc? Well, what if he's off that week? Does it go to a case management list? Because you can embed it into a registry. So is there someone that's always monitoring this registry? Is it a nurse practitioner that's just managing a hypertension clinic? So there are some organizations that are doing this really well in the wearable space where we are not there yet, just being totally honest. But I do think the wearables are one component. Then I think the other that I talked about last night with the physicians is genomics. Genomics is, I think the studies show that every 3 or 4 out of 5 drugs now have some sort of genomic marker being tested as it's going through FDA approval. And, depression meds, antipsychotics, blood thinners. I mean, a lot of medications right now have some sort of genetic testing. And that's additional cognitive burden to our docs. There is no way they are going to remember everything that needs to be done for your patients at any given time. So embedding that genetic data to alert you and say, oh, you're about to order Pradaxa. This patient isn't a candidate for Pradaxa because of their genetic profile. Please consider one of these others. And then the solution actually queues up what the other recommendations are. So I think between both the wearables and the genetic data, you can now move from predictive analytics to truly prescriptive care, which is the right patient at the right time with the right care, by really surrounding them with, the data and analytics and the AI on top of that.
Wow, that's amazing. I think that gets me into the future of healthcare delivery, right? Like, fast forward 5 to 10 years. What does a hospital look like with deeply embedded AI, according to you?
Yeah, so I think what will end up happening is, there's a lot of consumer grade things that are happening right now, like blood pressure cups and then, all the wearables and even telemedicine visits are, I think going to continue to expand. So I think in the primary care space, you're going to actually see sicker patients and the less sick patients are going to just kind of do their care at home. Even prescriptions that required an actual visit and a prescription can now be bought over the counter. So there's omeprazole used to be a prescription only. Now it's bought over the counter. So and also with a large language model and ChatGPT, people are going to start to self-care at home, I think, and then it's going to become sicker patients going to be seen in that primary care office, and they're going to manage those at home as best as possible. And therefore, your inpatient stays are going to be even sicker. And so, I think what we used to see in the inpatient space, some of these people that we would keep a little bit longer because they need some extra oxygen, and we're going to take care of those patients at home. And that truly would then leave the beds for the sickest of the sick. So I think we're going to really see the acuity in our hospitals going up as well too. But on the flip side, I think we're going to have more automation. We're going to have, these cameras in the rooms and the AI predicting the care. AI right now without an actual blood pressure cup is able to start detecting blood pressure, temperature, heart rate, just by cameras. So I think there's just more we would be able to do with the technical aspects and the technology surrounding the patient and the individual hospital room, so that that hospital room of the future, so you're monitoring these sicker patients kind of more around the clock instead of relying on people always going in and looking at them all the time.
Yeah, it makes sense. And are there going to be some new roles in healthcare because of these changes, or there's going to be a job shifting as well happening in healthcare because of this?
Yeah, I think we're going to obviously continue to have to upskill our folks. So, everyone's going to need to practice to their top of the license, but don't forget, we're also going, already in a nursing shortage and a physician shortage. So how are we going to face both, the clinical caregiver shortage? Well, we're going to need to upskill our CNAs. We're going to need to upskill our, transport team. So, the more we can upskill the folks that we may have, that they can maybe go into some of these other roles. I know some hospital systems are looking at, partnering with community colleges that, they come directly out of community college to go into some of these, these roles. But I think upskill and definitely upskilling on your IT team. So how to manage an AI model and, building, are you, a build or a buy program? And, your smaller community hospitals may continue to be a buy program. I think us at Beacon managing a large language model is probably not going to happen anytime soon. So that's why we partner. But, upskilling your team, but upskilling the clinical people as well too.
Awesome. Okay, so we are almost at the end of the webinar. Let's actually wrap this up with like a, lightning round. So like, 1 or 2 word answers, Dr. Johnston. So quickly ask these questions. One AI myth in healthcare for you right now.
That I think it's going to get rid of the caregivers anytime soon. In
Right.
the future, maybe 5-10 years from now, but right now we're not seeing that.
Okay, great. And one company doing it right?
I had to say right now, I'm really impressed with the Oracle and their clinical AI agent. And, so we're doubling down on our Oracle experience and going all in with their new agentic EHR.
Okay. And one capability that you wish existed today?
I really think just being like totally keyboardless, like ambient everything, just being able to have a conversation with the computer, a conversation with the patient, just, your thought process and, queuing up your orders, everything being totally ambient. I think it's coming, but we're not there yet.
Right. And this is probably interesting. AI as a co-pilot or autopilot in medicine?
I think it's both. I think for the most part, it should be a co-pilot in the clinical space, but I don't see any reason why it couldn't be autopilot in some of the back end processes.
Right. So finally, if you went back to being a physician today, how would you use AI differently?
Definitely, I would embrace it, is, seeing more and more patients, mostly just to finish on time and go home on time. The EHR is definitely hard work and it adds more clicks to the docs. And so if I could use AI to make my life easier, I would 100% embrace it.
Awesome. Well, thank you so much, Dr. Johnson. Thanks for your valuable time here with our audience. And I learned a ton about AI in healthcare and your journey from being a physician to now a technologist and some great insights. And thanks
Oh, well, thank you so much.
Awesome. But that's it for this month's AI Explained, folks. We'll come back to you with another great guest on in the month in the next few weeks. Then see you all.
All right. Sounds great. Thank you.